Welcome to the Diabetes and Ramadan International Alliance Virtual Congress Session 6. Our topic today is injectable and oral glucagon-like peptide 1 receptor agonist in Ramadan. My name is Dr. Hamid Farooqi. I am a consultant endocrinologist and the director of Dubai Diabetes Center. So we begin with the name of the Lord, Bismillah ar-Rahman ar-Rahim. These are my disclosures. So as we know, Ramadan is the 9th holy month of the Islamic lunar calendar. And fasting during Ramadan is an obligatory duty for all healthy adult Muslims. However, the Holy Quran does exempt those who are sick, medically unfit, or traveling from fasting during the holy month. It is very interesting that the population-based epidemiology of diabetes in Ramadan study done in 2001, which had more than 12,000 patients, indicated that nearly 80% of people with type 2 diabetes still fasted, and nearly half of patients with type 1 diabetes also did the same. Now, people with diabetes are on different medications, and the GLP1 receptor agonist and now the most recent GLP1 GIP1 receptor agonist combination is used very commonly. And because of its mechanism of action, the related GI side effects are always important when we start people on these medications. So very quickly, going over the incretin's mechanism of action. We know that incretins are gut hormones. The GLP1 receptor agonists are produced by the GLP1 itself is produced by the L cell, whereas GIP1 is produced by the K cell. L cells are seen in the colon and distal ileum, whereas K cells are present in the duodenum and jejunum. We are very familiar with how GLP1 receptor agonists work in terms of delaying the gastric emptying, increasing the diuresis, and so on and so forth. GIP1 similarly has an effect on insulin secretion, but also has some other effects that it does not share with GLP1, which is bone resorption and also fatty acid synthesis. So moving from the mechanism of action, going back to the fact that when you look at the pathophysiology of diabetes, what you definitely see is that there is a decreased incretin effect in the GI tract. There are obviously very well-known other pathophysiological mechanisms at work, such as insulin resistance, decreased insulin secretion, and increased glucose reabsorption. So we then have to think that the medications that we have that help us manage diabetes are from different classes that may have an effect on one or two or more of these mechanisms, but we don't have a single medicine that affects all of these factors. So again, in terms of the decreased incretin effect, we can give the GLP1 receptor agonist from the outside as injectables, and now more recently as an oral agent. Once again, there is a combination of GLP1 and GIP in the form of an injection that is also available. When you then go and look at the most recent guidelines, the 2023 recommendations for management of diabetes from the ADA, you will notice that healthy lifestyle and diabetes self-management education remain the basis of diabetes management. But when you move beyond those two and you are now into therapeutic intervention, the most important thing that you are looking at is cardiovascular risk. Does the person already have cardiovascular disease or is at a high risk? When you do that differentiation, then you notice that the GLP1 receptor agonists are pretty much under every category, whether the cardiovascular risk is high or cardiovascular risk is present. If you want to just manage the hyperglycemia or you're more focused towards losing the weight in individuals without these advanced cardiovascular risks, all of them have GLP-1 receptor agonists very high and in a very effective capacity, and therefore more and more use of this class of medications. Only in patients with heart failure, SGLT2 inhibitors have been preferred over the GLP-1 receptor agonists. So, in a nutshell, whichever the category of your patient is, GLP-1 receptor agonist would be a viable option for you to manage that condition. And therefore, once again, brings us back to the fact that a lot of patients are going to be on GLP-1 receptor agonists. How about the currently available GLP-1 receptor agonists? As you know, that they are broadly classified into short-acting and long-acting. The short-acting ones are the exenatide and lixisenatide, whereas the long-acting are your liraglutide, exenatide, dulaglutide, semaglutide. And semaglutide is the only one which is now available both as an oral preparation as well as an injectable. Moving on, we do know that when we are looking at the common adverse effects of any of these medications that belong to the GLP-1 receptor agonist class, the most important ones are nausea, vomiting, and diarrhea. Now, these are expected, and the good news is that they do resolve over time. People get accustomed to them. However, in the context of what we are talking about today, which is Ramadan, obviously, we don't want our patients to be vomiting because that will break their fast. So, therefore, it is important that this class of medications need to be thought through when either you are initiating them or when you are continuing their use during Ramadan. The other thing, away from the GI side effects, obviously is hypoglycemia. So if a person has hypoglycemia during Ramadan from these agents, then again, they have to break their fast. Therefore, this aspect is also important in the context of Ramadan. What we do note, and we are happy to note, is that severe hypoglycemic episodes, when we look at all these head-to-head trials, they were very rare, between the range of 1 to 2%. Obviously, minor hypoglycemic rates are more frequent than that, anywhere from 0 to 16%. Without sulfonylurea use, generally below 10%. Again, these minor hypoglycemic rates can go up considerably if the person is on sulfonylurea or insulin. The only exception is with the LEAD-6 trial, where if there was liraglutide combined with sulfonylurea, the rates were as high as 32.7%, and if it was sulfonylurea and exenatide, then the rates were high as 42%. So those two agents may have a higher chance of minor hypoglycemic episodes. Overall, what we can say is the concerns about hypoglycemia were minor when we look at the data from these trials. How about the injection site reactions? We see things like rash, erythema, or itching, which is very common with the GLP-1 receptor agonist, and more so with the longer acting ones as compared to shorter acting. Good news again here is that they are often transient. We see that patients who develop antibodies against this drug are the ones who tend to have more injection site reactions. As I said earlier, the only GLP-1 receptor agonist that is now available is semaglutide, and the oral medication is called Rybelsus. Here, the starter dose is 3 milligrams, which is used for the first month. Then the next month, the dose is increased to 7 milligrams, and if additional glycemic control is required, then you can go up to 14 milligrams after the second month. So 1 month of 3, 1 month of 7 milligrams, and then if you need additional help, then you can go up to 14 milligrams. There are certain things that are peculiar about how this medicine has to be taken, and all of you who are quite familiar with the precautions with the thyroid medication, the levothyroxine, this is quite similar to that, and it's easy to remember that way, that it also, oral semaglutide, also needs to be taken on an empty stomach with no more than 4 ounces of water. It should be taken at least 30 minutes before the food or beverage is consumed or any other medications are taken for that day. If you do not follow these instructions, the patient will have a lesser effect from the medication. So, in the context of Ramadan, if you are initiating oral GLP1 receptor agonist before Ramadan, please initiate it at least 6 to 8 weeks prior to the start of Ramadan so that you reach that effective dose of 7 milligrams well before the onset of Ramadan. Try not to go beyond that during the time Ramadan is in effect. You can do that after Ramadan ends. So again, avoid up titration or dose escalation within 2 to 4 weeks prior to Ramadan and definitely during Ramadan. What about starting injectable GLP1 receptor agonists before Ramadan? As I said earlier, that most GI effects which are of concern for people who intend to fast are reported in the first 2 to 3 days following the first dose, and it declines after each subsequent dose. So patients end up with having very minimal symptoms, if any, after a month. Therefore, starting an injectable GLP1 receptor agonist in the 4 to 6 weeks preceding Ramadan would not be advisable, as the GI side effects may prevent the individual from fasting. What about continuing GLP1 receptor agonists during Ramadan, the ones that are injectables? So, if the patient already has been taking the GLP1 receptor agonist and the GI side effects have resolved, it is fine to continue with the GLP1 analogs. It would be so the weekly or the long-acting injections can continue unchanged, as it is permissible to take this medicine while fasting. In terms of the short-acting ones, which we have as an example, the lixisenatide, which is administered once a day, it should be an hour before the first meal of the day, which is going to be iftar. Liraglutide is administered without regard to food, so anytime prior to iftar is fine. Exenatide is injected twice a day, so it has to be taken at iftar and at suhoor. What about fixed ratio combinations? So as you know, if we have a GLP-1 receptor agonist such as lixisenatide added onto insulin glargine in Soliqua, and we have liraglutide added onto insulin degludec in Ziltify. So in terms of Soliqua, it can be taken an hour before the iftar time. Ziltify can be administered at the same time each day with or without food. So again here, before iftar is preferable, and it helps us remember as well when to take when to prescribe the medicine for. Now, we do recommend, the DAR guidelines do recommend a 20 to 30% reduction in basal insulin dose if the A1C is below 7.5 at the beginning of Ramadan. Now, when you do that, obviously the dose of the GLP-1 receptor agonist will concomitantly go down as well. So it can lead to some effect in terms of the blood sugar control. So careful monitoring is necessary, and please use your clinical judgment. Very recently, a couple of weeks ago, we now have recommendations for titration and administration of the oral semaglutide during Ramadan. It was just published in December 21st, which is just last month. So here, Dr. Hasnain and his colleagues have given us detailed instructions with regards to oral semaglutide during Ramadan. So, as we have said earlier, people who are taking oral semaglutide should remain on their maintenance dose, whether it is 7 or 14 milligrams during Ramadan. Administration time, we need to talk to the patients and we need to make sure that both of us are on the same page. It is preferred to take it when breaking the fast at sunset, which is at iftar. Then go forward with the Maghrib prayer, then come back and eat, and that would fulfill the requirements of what is required with semaglutide administration. That is, it should be administered on an empty stomach, no more than 120 ml of water, and wait 30 minutes before eating, drinking, or taking any other medications. So this is a graphic representation. You can see iftar followed by oral semaglutide in 120 ml of water, 30 minutes, which it would take for you to go ahead and have Maghrib prayers, and then come back and have the iftar meal. Now, that is basically an ideal situation, but there are going to be individual differences, local differences in how Ramadan is observed. So there are going to be deviations from what we just talked about. As long as these deviations are once or twice here or there, that should not make much of a difference, but regular deviation or persistent deviation may lead to changes in absorption and efficacy over time. Let's look at quickly some examples of deviation. Administration of oral semaglutide 30 minutes before suhoor instead of iftar. Generally, now between iftar and suhoor, we don't have a 6-hour gap. If it is, then it's okay. But if it isn't, then the absorption will be affected. Absorption will be similarly affected if an increased volume of water, so maybe double from 120 ml is taken. It will also be affected if you eat food at the same time, even one date, right? Absorption will be affected. And if you eat earlier than 30 minutes, again, the absorption will be affected. Finally, I'll end with the most recent available GLP1, GIP receptor agonist, which is Mounjaro. Here, it's an injectable, started for the first month at 2.5 milligram, titrate up to 5 milligram once a week. Then, just like the other GLP1s, if additional glycemic control is needed, you can go from 7.5 to 15 milligrams once a week. Again, try to get to 5 milligram at least 4 to 6 weeks before the onset of Ramadan so that the person is on a stable dose, and once Ramadan ends and the glycemic control is not achieved, you can then start titrating upwards from 7.5 to 15 milligrams based on your clinical judgment. So, to conclude, what are our take-home messages? First, fasting in Ramadan is an obligatory duty, but there are certain exceptions. There are multiple organs in the pathophysiology of type 2 diabetes. One of them is the GLP1 receptor agonist, and the second one is the GLP1 and GIP receptor agonist combination. Given their mode of action, GI side effects are important, particularly in context of Ramadan. Hypoglycemia can also occur, but more so with sulfonylurea or insulin use. Do not initiate GLP1 receptor agonist or the combination of GLP1 GIP just prior to Ramadan because of the side effects. Those on a stable dose of long-acting formulation can continue using it safely. Short-acting insulin injectable GLP1 receptor agonist should be taken before iftar. And finally, oral semaglutide can be taken off at iftar on an empty stomach with 4 ounces of water with the meal half an hour later. With that, I conclude. I thank you for your kind attention, and I wish all of you a blessed Ramadan. Thank you very much.